Good morning.
Good morning.
Good morning and happy 2024.
Happy New Year, Dr. Garcia.
Happy New Year. So this is going to be our first Instagram Live of 2024 and something that we hope to do, that we will do.
We will
do every Tuesday at 9 a.m. I know this is not the most convenient time. I know there's many people who are working, but this is going to be saved on our Instagram channel. We're also going to be recording on YouTube and putting them on YouTube as well. And really, we just wanted to get the information out there.
Yeah.
I think like we were trying to be too perfect. We're trying to be too perfect and trying to get it done.
Talk about being too perfect.
I know, right? I did put my phone on Do Not Disturb.
Yeah, we're gonna work out the kinks. We're gonna work out the kinks, guys.
We were always trying to get it, 6 p.m., 7 p.m., and that was just making it more difficult for us to get out there because it's just a really busy time with work and family and feeling tired. We're both morning people.
Yeah, we are both morning people. This is our prime time for being productive, for doing this kind of stuff. So that's why we decided, you know what, it's better for us to get the information out there and have it saved, and to be able to do it more often rather than kind of be a bit more sporadic, which has been challenging for us to say the least. So this is one of our New Year's resolutions.
That's right.
Yeah.
Just one of many. There's more to come, but we can't tell you everything now because that's going to spoil the big surprise.
Yes, we're very excited.
All right, so you guys have submitted your questions, and that's great. We have them all here on paper. So we're gonna answer as many as we can. We're gonna try to make this about 30 to 45 minutes. If you have questions that you wanna ask us live, you can do that as well. But before we start answering the questions, we wanted to talk about something that comes up quite often.
Yes.
And we wanted to sort of clear out this concept. And the thing that we're talking about is this concept that I hear out about getting your fertility check.
Yeah.
So there are some fertility clinics advertising, come for a fertility check. There's people on social media saying, make sure you go and get your fertility checked. There's people saying, listen, before you even start trying, we get consults all the time. I'm not trying, I'm in a relationship, but I'm single, but regardless, I'm not trying. I want to maybe get pregnant 3 years, 4 years, 5 years, and I want to make sure everything is perfect for when I try.
Yeah.
What do you think about that?
Oh, this is a really tough one. And on one hand, I gotta say, I'm so glad that people are thinking about their fertility and that they're thinking ahead about these things, and that it's not become like automatic that, people will not have difficulties getting pregnant. People are realizing that infertility is common and it absolutely does happen. So I really applaud that. And I applaud the idea that people are thinking about, some of the testing we do in fertility. However, and there's a really big however, there is absolutely no way to really know whether someone will be able to get pregnant at a given time with or without a particular partner. There is just simply no way to really truly check somebody's fertility. I always tell people, fertility is like this 1,000-piece puzzle. And, the tests that we have maybe look at a couple of pieces. Some of the pieces may be missing, partner, not partner, in terms of where the sperm may be coming from. And then a lot of the pieces we just don't see. We just don't know. We just don't understand. And so really there is no way to really be able to tell someone, yep, you're going to get pregnant, no problem, or otherwise. I mean, what's your take?
Yeah, no, absolutely. And I worry, we see consults like this and we do some testing because people are here for a reason. Yeah. But I do worry about the false sense of reassurance. So I'm really big at saying, yes, your tests are fine, but that doesn't mean that you can now be confident that pregnancy is going to happen when you want it, because the last thing that I want is people coming back to me 2-3 years saying, I don't understand, you told me it's going to work, what's going on. So I do worry very much about the false sense of reassurance that this concept of I got my fertility checked and everything is fine will give patients. So that's one thing to talk about. And the other thing is, the best way to interpret fertility tests is in the context of infertility. In other words, you can come for your tests and let's say there is a little polyp in the uterus. Let's say your AMH level, it's not 25, let's say it is 5 or 7, which is a little bit on the low end. let's say you do a semen analysis and the motility is just a little bit off, the counts is like, let's say 10 million as supposed to be 50 millions, then it's really hard to interpret that, because there are lots of people with those kind of tests that have no problem getting pregnant. So it's one thing when you come to us saying, I've been trying for 2 years, here is my semen analysis showing that it's 10 million versus 50 million, here is my uterus showing a polyp and whatnot, then you can say, okay, you've been trying for 2 years, nothing is happening, there's this test showing these results. These tests have meaning, they have value, because you really have been trying and pregnancy hasn't happened, so let's address these results. But when you haven't been trying at all, I would have a really hard time telling somebody with a borderline semen analysis, oh my God, don't even bother trying, go straight to IUI, go straight to IVF. I would never say that. I would say, yeah, here are the results. These are all the things that you should be doing in terms of sperm, which we're going to be talking about in some future episodes or Instagram lives. But I wouldn't necessarily say, A, you can't get pregnant, or B, you need fertility treatment off the bat. So I think it's really important to understand the limitations. If we do a semen analysis and it's 0, then yes, I could say, okay, you saved yourself a year of trying, there is absolutely no sperm, then we gotta do something about that. If you,
but let's say, how often does that happen?
Never, like very, very rarely.
let's
very,
be clear,
very rarely, exactly. Most of the time it's either normal, which again doesn't guarantee it's gonna work, or it's borderline, which kind of leaves you in this, place of anxiety and worry unnecessarily, because for all you know, in reality, once you start trying to conceive, everything it's okay. And that also brings into the questions I had to say. I was in a Facebook group the other day, and somebody was mentioning, I'm 38 and I'm thinking about fertility, and I have a partner, I'm not really sure about him, like, my timeline, my clock is ticking. And then somebody said, oh, don't worry, I was in the same shoes, I was 42, I decided to wait to be sure I was the right partner, and then at 43 I got pregnant right away, so don't worry, you're fine. Like, come on, and this is the problem, right? There is no way of telling who you're gonna be. So this 38-year-old woman could very well be as lucky and wait until she's 43, and then bam, first time, second time, third time, healthy live birth. It does happen, but you don't know if you're going to be that person, and this is what we're talking about. There is no way of predicting who is going to be that. Now, if you get to be to that 40, 41, 42, and you happen not to be the lucky one that gets pregnant instantaneously, and you're looking at fertility treatment, then that's where it becomes complicated, and the whole thing about age and fertility, and you can't reverse that. So I'm, as you know, here at Markham Fertility Centre, we're women-led physician clinic, we're big-time feminists, and we hate the pressure that gets put on women all the time to conceive and have children. And I certainly wish it wasn't the case, but the reality, the biology is that, the clock is ticking, and that's why there are options like freezing your eggs and whatnot, which we can get into another time. But certainly the take-home message is there's just no way of predicting who's going to have problems and who's going to not have problems, unless you're having a semen analysis that is very definitive, like 0 sperm, or you do a test and you're in complete menopause. But honestly, you don't need to do a test for that if
you got the symptoms.
If you got the symptoms, you got the symptoms.
I think another really important thing to point out, though, is that none of these tests are static. So what I mean is that just because you have a test result that comes back a certain way now does not mean it's going to be the same even in a few months. Especially sperm tests. They are so variable over time. And so I've had lots of patients who come for a fertility check. We do a semen analysis. Again, maybe it's like so kind of borderline motility count, whatever. So we say, well, maybe this might cause issues, but let's repeat it. And so men make a whole new cohort of sperm about every 3 months. So we typically repeat the sperm test. I usually try for a month and a half to 2 months. And then it could be totally normal. And then they're like, well, how do we interpret that first sperm test? It's like, well, who knows? Could have just been truly just an off day, off week, whatever. any kind of illness, whatever fever that you had in the 3 months leading up to the sperm test can affect the outcome.
Right.
And there is always just this variability too. And I think that that's a really hard one as well.
Right.
And then this poor, couple, let's say in this case, may have been stressed to the max for 2 months, being like, oh my God, we're going to have fertility issues. We're going to need fertility treatment. How are we going to do fertility treatment? How are we going to pay for it, et cetera, et cetera. When really it was unnecessary to start with.
Yeah. This reminded me when I was back in the day when I started trying to build my family. It was in fellowship. I was training to become a fertility specialist. I was about 31, newly married, and me and my friend, of course, decided to get an AMH level together because that was the cool thing to do. That was silly, right? So mine was 26, which is very good, and hers was 3, which wasn't very good. And of course, she's freaking out, tears, I'm consoling her, all the things. Fast forward a couple of years, guess who has 5-year history of infertility, 5 IVF, 8 transfers? Me. Guess who got pregnant on the first try, the day she took out the IUD? She did. And then who got pregnant again right away, a year later? Yeah. She did. So this really, and we still got great friends, and we laugh about it all the time, but it really drives home the point that there is just no way of knowing. There's just no way.
Yeah, along those lines, for myself, I have never checked my AMH.
She does practice what she preaches.
Yeah, because I know that, so a lot of people will patients will come to me and they'll say, oh, I really want to know my AMH, I want to know my egg reserve because I want to know my fertility, get my fertility checked, I heard about this test, whatever. And I say, listen, whether your AMH is high or low doesn't really predict whether you're going to get pregnant naturally or not. As well, like it's one single point in time. So just because your AMH, will say it's 26, at one point, doesn't mean it's always going to be high, and it might drop a lot over the course of the year or not at all. It's very unpredictable. Like we don't know. Everybody is different. Every AMH is different. Every set of pair of ovaries are different. So that's why I've never checked my AMH, because I know that it won't predict whether I'll be able to get pregnant or not. And I know that if anything, it'll just cause me anxiety for potentially no possible reason, if, for instance, if it were to come back low.
Right.
So, and I always tell patients that, to sort of say, like, listen, like I'm not just sort of, talking out of the textbook, right? Like this is actually what I truly believe in, that, because that anxiety and that added pressure of trying to figure out, okay, am I going to have kids now? Am I going to have kids with the person I'm with now or not?
Right.
It's a lot. And it shouldn't be based on a blood test. It should be based on bigger life choices, right?
Absolutely. All right. So we're going to start answering your questions.
Yes, let's do it.
Shall we? Okay. So the first question is, my BMI is over 30. Is it okay to go on a weight loss plan with diet and exercise while trying to conceive at MFC? So the answer to that question is yes, it is okay. A weight loss plan has to be realistic. So healthy weight loss is about 1 to 2 pounds a week. Nothing more crazy than that. You want to make sure that you're getting a good amount of protein, like high amounts of protein, actually good amounts of carbohydrates and fats, and really good hydration, like at least 3 liters of water as well. Exercise is also great. You can do resistance training, you can do cardio, you can do yoga, you can do swimming, you can do the exercise bike. But the important thing is to make sure that you're not going too much, that you're taking your days of rest, that you are able to breathe and talk while you're doing exercises, and if you're not, only for a short period of time. That's what HIIT exercises would be. And there isn't a perfect exercise that you need to do for fertility. Any exercise is good exercise. I would recommend a combination of resistance training and cardio. Cardio could be like the steady pace cardio, or HIIT exercises as well. Those are great. But yeah, certainly you can. I don't like to use the word diet, but certainly you can look at nutrition and exercise while you're trying to conceive, and that would be a very good idea.
Along those lines, it's also important to point out, because I'm getting a lot more patients these days asking about Ozempic.
Yeah.
So, working on weight loss, improving your diet through, healthy foods, getting more exercise are great. But once you start getting into certain like weight loss supplements, and the prescription medications like Ozempic, that's where we may come into concerns in regards to fertility. So for instance, something like Ozempic, Right now, I think most people are probably recommending you should be off of it for about 2 months before trying to conceive.
Exactly.
All right, so another great question that we got. So how does baby aspirin help a pregnancy after 12 weeks? This is a great question. So when we're talking about baby aspirin, we're talking about 81 milligrams of aspirin. So it's sometimes called low dose aspirin, sometimes called baby aspirin. It's also called acetyl salicylic acid, or ASA. So this actually comes from the obstetrical literature as opposed to kind of more the fertility literature. But in the world of obstetrics, there were many studies that have shown, and there's guidelines saying that patients who are at higher risk of developing elevated blood pressures in pregnancy, sometimes also called preeclampsia, to prevent that, they should be on 162, so 2 baby aspirin, or 2 times 81 milligrams of aspirin every day to help prevent elevated blood pressures in pregnancy, preeclampsia. Now, when you look at the hypertension guidelines in pregnancy from for instance, the Society of Obstetricians and Gynecologists of Canada, they set out a bunch of risk factors for people who should be doing this. But really, they're quite broad. So patients over the age of 35 should just all be on ASA 162 milligrams. Patients who get pregnant after assisted reproductive technologies like IVF should be on 162 milligrams. The reason is that aspirin's a little bit of a blood thinner. It's a little bit of an anti-inflammatory, and it's shown to improve the blood vessel connections between the placenta and the uterus, because it's thought that these poor blood vessel connections create this sort of poor blood flow through the placenta that increases blood pressure to try and force the blood through the placenta. And so that's why aspirin is really helpful. So this is really from the obstetrical guidelines, and so there's lots of research around that. So for the vast majority of the patients I see, for sure I will be recommending ASA 162 milligrams every day. In fact, the guidelines actually say you should take it at night. Nobody really knows why.
I think that's how the study was
Yeah,
made.
that's just how the study was done.
Duplicating the study, yeah.
So, I mean, I tell people 162 at night. I have no great reason for the at night part, but that's what the study said.
Right, but exactly. But prior to 12 weeks, during fertility treatment, we're doing 81 milligrams. And then we go to 162 milligrams, which is 2 aspirins at 12 weeks, until about 35 weeks.
Yeah.
All right. So here's another question. A celebrity with stage 4 breast cancer said IVF treatments caused her cancer. Can you speak to this?
Oh, this is a good question. It's a really good question.
Do you know which celebrity this would be? I don't know. I haven't heard this.
I don't know.
Yeah.
The only celebrity I can think of who has breast cancer is Shannon Doherty, like from 90210, but I don't know if she did a bunch of IVF. If somebody knows in the comments who this celebrity is, please, I'm very curious. Celebrity gossip and celebrity.
Yes, but this is great, and I mean, this is great. So the answer to this question is there's absolutely no evidence whatsoever that IVF causes cancer. So this was actually very well studied. Very, very well studied.
Oh, somebody said it is Shannon Doherty.
It is Shannon Doherty.
Thank you.
There you go. Thank you. So this has actually been very well studied. This is not a stipulation. It was being published in every major journal. And I will try at some point to find the reference if anybody wants it, and I'll share it. But basically, they looked at women that had been taking fertility treatment, fertility drugs over a long period of time, and there was no incidence of breast cancer or ovarian cancer at all. Now, one thing that we do know is that, unfortunately, infertility, not fertility treatments, but infertility, which would be defined as not having children over your reproductive time, that is a risk factor for breast cancer and ovarian cancer if women were not on the birth control pill. So if you have somebody who decides, I do not want to have children, period, I'm going to be in the birth control pill through my entire reproductive life until I'm menopausal, that person would never have had children. But because she was in the birth control pill through that whole time, she actually has lower risk of ovarian cancer.
Yeah.
If that same person wanted to have children, was not on the birth control pill, and went through the entire reproductive life with infertility or just not having children, period, but no using the birth control pill, then that person would have an increased risk of ovarian cancer specifically.
Yeah, the number that's always sticks in my head is that if you're on a birth control pill for 10 years, your risk of ovarian cancer is halved.
So now that's ovarian cancer. Breast cancer the birth control pill doesn't decrease the risk of breast cancer in the same way that we just talked about decreasing the risk of ovarian cancer, but it also doesn't increase your risk of breast cancer. And we do know that, again, infertility is a risk factor for both breast and ovarian cancer. So to summarize, it is not the IVF treatments. Maybe in her case, I mean, I don't really know who she is that well, so I don't know if she has children, didn't have children, but but it is infertility that is a risk factor for breast and ovarian cancer, but the birth control pill can significantly decrease the risk of ovarian cancer. It's a great question.
All right, so this is another great question that you sent in. Okay, what's the ideal amount of time to wait for another embryo transfer after giving birth? This is a question that comes up a lot. Usually what people are about 12 weeks pregnant. They're already planning baby number 2. I'm like, okay. So basically, so let's say, you know, somebody has a successful embryo transfer and now they're pregnant, and, you know, we're seeing them at, you know, let's say their 12-week prenatal visit, and they're kind of going to be transferring care to their OB provider, let's say. So I would say, you know, get through the pregnancy, of course. Once you deliver, it will depend. There's a couple of factors that will depend on. So we generally sort of say, you know, we want you to sort of be cycling again. So your menstrual cycle being back. That can happen usually within about a year after delivery. It will vary depending on whether somebody breastfeeds and or pumps versus not. And again, we don't know whether somebody will do that, and so you can't really predict whether you're going to be able to do that or whether you're going to want to do that at the time of when you're still pregnant. So generally when your cycles are back, then we can think about potentially planning for another embryo transfer. Couple caveats to that. So number one, let's say somebody has a cesarean section for their delivery. Again, the obstetricians will often say that you want at least 18 months delivery to allow the uterus to heal completely. So it's delivery to delivery. That's very important. So that basically means that you could get pregnant potentially 9 months after you have delivered, right? Again, that's just to allow the uterus to heal. If somebody were to get pregnant before that, it's okay. It's not a bad thing. It just means that they would be less likely to offer you a vaginal delivery after your C-section, and then they may suggest just having a second cesarean section. The other caveat that I think is important to point out, if somebody has really irregular cycles, let's say going into pregnancy, or let's say they're perimenopausal or menopausal going into pregnancy, then they're like, well, how do I know when my periods are back? I mean, I only had a period every 6 months anyway. That's a little bit trickier. That's a little bit more difficult to kind of navigate. But I think usually sort of around 6 to 9 months post-delivery is a great time to sort of think about, you know, coming back to see us, having a discussion, potentially doing some tests so we can sort of see where things are at, and then planning for an embryo transfer. But I mean, that process can be, you know, from the time you see us to the time you're doing the transfer, could be, you know, 2 months, maybe 3 months potentially, if there's something that we need to remedy or something to work on before we get started.
Right. And another thing to add to that is basically how many embryos you have, what is the quality of your embryos, your age, and the number of children that you want to have. So let's say you are 39 and you have 1 embryo left that is not genetically tested, that is poor quality, and you know that you want to have more than 1 child. Let's say you have 1, you want to have 2, you want to have 3. Well, you need to hurry, because if that 1 embryo that you have frozen doesn't work, then you might need to consider doing more IVFs, and the younger you are when you do that, the better. If on the other hand, you're 36, you made 6 euploid embryos, you transfer 1, you're pregnant, you have 5 euploid embryos left, then you don't need to hurry as much, because over 4 or 5 euploid embryos, there is a very good chance that there is another second or third child in there. I have to say, we're freaking people out because they think we're drinking from the same cup. Can you just show your cup?
Oh God, no, we're not that weird.
Somebody said, wow, you guys are really close at it. We're not that close.
I saw these and I thought it'd be cute if we had matching cups.
So yeah, Marta bought this for us, but it's 2 separate cups. Mine's on this side, hers on her side. We're not mixing the cups.
And for the record, the fluids in our cups, so I've got tea, a little bit more brown, hers is a little bit more yellowy, so we're very clear on whose cup is whose.
And mine's just really water with apple cider vinegar, so if she tasted that, she would probably spit.
Yeah, it would not go. I've tried that before, and
so good. So now that that's clear.
didn't even think of that one.
Yeah, because you're taking one and I'm taking mine. People don't realize that.
It makes sense.
It's a good question. It makes sense. All right. The next question is it beneficial to do a sono before an IUI? Does it increase your chances of success? So first of all, what is a sono? A sonohistogram is a test that looks inside the cavity of the uterus. We want to make sure there's no septums, no polyp, no fibroids that are inside the cavity of the uterus that can interfere with the success of an IUI or a frozen embryo transfer cycle. And it can also look at the fallopian tubes by using contrast to see if they're open. So it is an important test to do when you embark on a fertility journey because we want to know that information and it can help us plan whether IUI or IVF would be better for you depending on the status of the fallopian tubes or whether or not you need surgery to remove a polyp or a fibroid prior to fertility treatment. So certainly it's a good test to do when you start your journey and it's certainly a good test to do before an IUI. Now, I don't think you need to do a sono before every IUI. So a sono is something that you do the beginning of your journey, everything is clear, the tubes are open, then your plan for IUI gets put in place. Usually we recommend about 3 to 4 IUIs before sort of sitting down and looking at what's going on if it hasn't worked, and we can talk about why that is in another episode all about IUIs. So I don't recommend one before every single IUI, but certainly one sono about sort of 6 months or so before starting the IUI journey. Mm-hmm. And does it increase your chances of success? Well, if you don't know if your tubes are open or blocked and you're doing IUIs, then that certainly can be an issue. So you want to know that. If there is a polyp or a fibroid and you're doing IUIs and you don't know this, that can be an issue as well. There is a theory that doing a sono would increase the chances of natural conception because it's essentially flushing out the tubes. That is a very, very small increase. So I certainly do encourage people when they're doing their sonos, hey, try this month, try next month, try over the next few months so that you can kind of gather that little bit of an increase in pregnancy rate. But that doesn't mean that you should be doing a sono before every IUI. Absolutely not. Yeah,
and flushing the tubes every month. It's like a one-time thing.
Right, exactly.
That would be helpful. It's not something you need to keep doing for sure.
Exactly. Do you want to go to the next page?
Or? Yeah, let's do the next page. Let's see what we got here.
I think this is the same page.
So I think that this is a really good question. It kind of speaks back to what we spoke about earlier. Somebody asked, does low AMH at 31 years old impact the chances of getting pregnant without assistance? So, we talked about this earlier, but I think it just goes to show you that this is a really important question, a really common question that we get a lot. And that's that, AMH in and of itself does not predict whether somebody can get pregnant, when they're going to get pregnant, whether they're going to have issues getting pregnant. An AMH, I sort of, to keep it really basic, I sort of saying AMH is a good test for me as a fertility doctor because it tells me what dose of medications I'm going to give you in a stimulation cycle. Right?
How many eggs we're gonna get?
And and it roughly helps us figure out how many eggs we might get as a predictor in terms of kind of letting people know what their odds of success are. The other thing is that AMH also doesn't really give us a lot of information about egg quality, right? So somebody at 31 with a low AMH versus 41 with a low AMH are still have very, very different odds of conceiving and risk of miscarriage as well. Mm-hmm. And egg quality is way more important than quantity, which is what AMH is predicting. Quality really trumps quantity for sure, all the time. Mm-hmm. Yeah. Mm-hmm. So even if you find out that you have a low AMH at age 31, it's okay. It's not the end of the world. It does not mean that you're not going to be able to build the family that you want. Mm-hmm. It might encourage you to sort of start planning for the future sooner rather than later. Mm-hmm. So depending on your situation, potentially freezing eggs, potentially maybe doing IVF to freeze embryos to use for the future, right? So that you can potentially have baby number 2, number 3, depending on what your plans are. So that might sort of prompt you to think about that. But in terms of getting pregnant without assistance, it does not affect your chances.
Exactly. Mm-hmm. There was another question about AMH that I saw back, since you're talking about AMH. I don't see it here now, but the question is, can you do something to increase your AMH? And the answer is no. There is no actual thing that you can do to quote unquote increase your AMH level. So that's kind of sort of set in stone, so to speak, and a lot of it is genetic, a lot of it is related to age. However, there are some things you can do to increase the quality of your eggs, and Dr. Wais is absolutely correct. That is much more important than, hey, I moved my AMH from like 7 to 9. That doesn't matter that much as I've done all of these things to improve the quality of the eggs. So we'll do a whole thing about egg quality altogether, but very briefly, the common sense: avoiding smoking, alcohol, drug use, good nutrition, good exercise routine, good sleep, good hydration, and then there's supplements. The main one is coenzyme Q10. There's many other out there as well that we'll talk about in detail in another time, but certainly concentrating on egg quality is something that you can to some degree influence. It's not so much the egg quantity. Let's see, we are getting close to the half an hour mark, but let's answer a few more questions here. Can you discuss the issues with having endometriosis and the impact on fertility that it may have? So great questions. We can talk about this for a whole hour.
Well, we did a whole Instagram live on endometriosis. Yeah.
So endometriosis is a condition where the tissue that belongs inside the cavity of the uterus is now spread throughout the pelvis. It could be sitting in the ovaries, in the bowel, in the rectum, in the bladder, and it can cause inflammation. There's the only way to really know for sure if you have endometriosis is surgery. And surgery is usually a laparoscopy where you would go in under general anesthesia and take some samples of the tissue that looks like endometriosis, and then send it to pathology, and they can look under the microscope and say this definitely is endometriosis. There is other types of tests out there like CA-125 and Receptiva tests and endometrial mapping, and they have varying degrees of diagnostic power, but nothing really compares to endometriosis and pathological evaluation.
Yeah, for sure, it's still definitely the gold standard.
Exactly. So the question of endometriosis of infertility is a tricky one, and it comes quite often. So I usually, when patients say, hey, should I go and get a laparoscopy for endometriosis because I'm worried and I'm trying to conceive and I wonder if it's an issue, the evidence would say that the main reason to do a laparoscopy for endometriosis in the context of infertility is if there is significant pain that is interfering with your quality of life. So, every time you get your period, you're taking narcotics, you can't go to work, it's very severe, real pain, with, very difficult pain with asexual intercourse and penetration, making it, trying to conceive very difficult. So that would be one reason. So pain interfering with your quality of life. Another reason is having large endometriomas that would prevent IVF from happening. So if both your ovaries have 8-10 centimeters endometriomas, they're taking over the entire surface of the ovary. You're not able to access any follicles or any eggs. Then absolutely that would be a reason to do a laparoscopy. And the third reason is if there is a hydrosalpinx or a swollen fallopian tube. So if you have a swollen fallopian tube and otherwise normal ovaries that are accessible, the recommendation would be to do IVF, take out the eggs, make embryos, freeze those embryos, genetically test the embryos ideally, but that's a different discussion. And then once you have the embryos already made and frozen and ready to use, then you go for surgery to remove the hydrosalpinx, because we know that a swollen fallopian tube can decrease the chances of implantation.
And along those lines, I think it's important to point out that really endometriosis surgery, I was
gonna get to that.
I think ideally, really, we would love people to do egg retrieval first, make embryos, know that we've got good embryos, then do surgery, especially if you're going to remove endometriosis cysts, because removal of endometriosis cysts, they're scarred, they're sticky. When you're actually doing the surgery and physically removing from the ovary, like, you are inherently going to cause damage to those follicles and around the eggs, those baby eggs that are in the ovary as well. And for sure that can cause significant detriment for people who are stimulating before surgery or after surgery. I mean, I've definitely seen big drops before in patients who've done surgery, let's say between stimulations. And so, we can kind of do an AMH to kind of check what you are like, going into surgery and post-surgery. But at the end of the day, AMH is just a predictor. How somebody stimulates is the what we're actually looking at, right? It's a much better measure as well. And I think that that's, you know, I think more and more we're sort of getting into this idea that, yeah, the perfect, so to speak, plan is make embryos, do the surgery, get the pelvis looking as beautiful as possible, and then plan on embryo transfer. I think that's like worth reiterating.
Absolutely. The next question is, are support persons, partners able to go with patients for certain tests or procedures at Markham Fertility Centre? And the answer is yes, COVID is over, yay. So for egg retrievals, partners are in a different room because the patients will be asleep under, we can say under anesthesia, but
deep sedation.
Deep sedation. There is an anesthesiologist in the
term.
room, and patients are fully asleep. So we ask partners.
They get offended when we say fully asleep.
Yeah, I know,
they are
like
in a light sleep.
So partners are in another room. For embryo transfers, partners are in the room during the embryo transfer. So it would be the patient, the partner, the physician, and the technologists in the room, and then the embryologists are on the other side of the room handing over the embryos. For procedures like ultrasounds or sonos, partners are welcome to come. We do ask them to wait outside. If it's a pregnancy ultrasound, partners are brought in at the end to see the baby move and all the cute things, but technologists do need to concentrate and do the measurements and things like that. And for sonos, usually partners wait outside, but if there's a patient that says, you know, I really need my partner to be in the room with me, we make things a lot better and more comfortable for me, then we can certainly accommodate that.
For sure, absolutely. And of course, for embryo transfers and IUIs, we really welcome partners.
Oh yes, for IUIs as well. Yeah, I forgot about the IUIs. That's right. Okay.
Okay. Any other questions? Any questions that we don't answer, we'll definitely keep in our
bank.
bank.
I think there is one here where you're looking. I'm gonna find
our next week.
I'm gonna find one here. If someone did a sono before coming to an appointment, would you test for AMH? Well, sono and AMH are two separate tests, and they're both part of the fertility workup. When Dr. Wais was talking about not doing an AMH, she was talking about not using an AMH has a reassurance that fertility is going to be fine, or not using an AMH has a way to say, I haven't even tried and now I need fertility treatment. That's what she was talking about. But if somebody's coming with fertility concerns, or somebody's wanting to freeze her eggs, then we would definitely do an AMH, because we need that information in order to determine what is the number of eggs that we're going to get through an egg retrieval and what dose of medication to give. And if somebody's trying to conceive, then a sono and AMH, both of those tests separately are part of the fertility workup that we would do with somebody with infertility. So the answer would be yes, we would do an AMH.
It's worth noting also that AMH is not covered. So if you live in Ontario, AMH as a blood test is not covered by OHIP, meaning that you do have to pay out of pocket for it. Last time I looked, I think labs charged somewhere around $85 or so, just kind of ballpark. But yeah, it's not covered. Maybe covered by your private insurance plan.
Okay.
Yeah. Any other questions on here? Let's
There's
make
nothing
sure.
else. No.
Oh, perfect.
Yeah,
okay, good.
Yeah.
All right. And do we want to
a couple more?
Yeah.
Let's do a couple more to 45.
So how long after your pre-testing can you typically start with IVF? So really, when you're doing pre-testing and you're coming in for your first appointment, at that appointment, you might be writing your IVF cycle plan. You may potentially be able to be ready to go even the following month. So, you know, from pre-testing to actually be able to start your IVF could be as short as, I don't know, 1 cycle, maybe 2 cycles. It will depend on whether there's any issues or concerns that come out of the pre-testing, things that need to be managed or things that could be optimized before going into IVF. But certainly we can move quite quickly once we have all of our test results.
Exactly. There's another question here that's saying, can we start testing? I think I saw it back. Can we start testing? Oh yeah, is it possible to start measuring serum progesterone after embryo transfer?
Yeah,
please.
Common question, yeah.
Somebody said please. So, I mean, we can always do a test, but the problem is every time you do a test, you gotta think, what are you doing about that test? And the reality is that there is no established level of progesterone that can tell us this embryo transfer, it's working, it's going to work, or it's not going to work, or it's progressing or not progressing. So, you know, if we check your hemoglobin, we know if it is after, like, under a certain amount. Let's say we check your iron levels. If it's under a certain amount, you treat with iron. If it's or above a certain amount, your iron stores are normal. We know that number. We know what that number looks like. When it comes to progesterone, that number just doesn't exist.
Yeah.
So then there's really no value in adding the progesterone because you don't really need to increase the dose or decrease the dose or counsel patients differently. We know that pregnancies that are progressing because of an issue with the pregnancy are going to make a little bit,
not the progesterone. Yeah.
With the pregnancy, not the progesterone, I'm going to make lower progesterone, but that doesn't mean that increasing the progesterone is going to make the pregnancy now do well. The reason the progesterone is low in the first place is because the pregnancy is not progressing well, and the pregnancy is not progressing well likely for reasons that are not related to the progesterone. It could be related to embryo quality. That's the most common reason that pregnancies don't progress, even with diploid embryos. So this is why we don't test. I know patients ask all the time, and it's not to be difficult. It's just, again, everything that doing a test is easy. Yeah, you can do a test, but then what do you do with that test? How do you cancel that patients? We don't ever want to give you false reassurance to say your progesterone level is great, like that means everything is going to be perfect, or to say your progesterone level is low, now let me increase it and I'm going to save the pregnancy. It just doesn't work like that.
It really doesn't work that way, unfortunately. And the other thing is that there's so many different types of progesterone. So progesterone, just like estrogen, it's a whole family of hormones. So it's like, what type of progesterone are we looking for? Which type of progesterone is more predictive of pregnancy versus not predictive? Progesterone in and of itself is very cyclic. So even if you have somebody who is, let's say, spontaneous pregnancy, and you were to measure their progesterone, let's say, 5 days in a row, you're going to get very different numbers. And the other thing is that when we're measuring progesterone, we're checking the blood test, right? We're checking the level of progesterone in your blood. That doesn't necessarily reflect the level of progesterone in the uterus. And that could be very different, and that is probably much more important and relevant to pregnancy, whether pregnancy will succeed. So, I agree, we can test for it, but we don't know what to do with the results, and we would never, there's no number to target.
Exactly,
right?
Exactly. And that goes to the next question here. How much PIO dosage for an FET? How do you determine the appropriate dosage? Again, it's not determined by anything other than standard protocols. So there was a study published looking at the dose of 50 milligrams IM a day or 50 milligrams every 3 days with vaginal progesterone in between for a medicated frozen embryo transfer. This was a really big study. It was randomized, and then it showed the pregnancy rates were the same if you're doing 50 milligrams a day of progesterone oral injections versus 50 milligrams every 3 days with vaginal progesterone in between those days. So there was no difference in pregnancy rate between those two groups. So the dosage of progesterone have been established over a long time, basically based on studies that have been done showing pregnancy rates and not based on individual factors.
Yeah.
All right. There is another question saying, I'm 32, no clue about egg freezing. Where do I start? Where and how to start? So great question. 32 is the perfect time to start thinking about egg freezing. So the best place to start is to request a consult with a fertility specialist. Here at Markham Fertility Centre, we do lots of egg freezing, of course. She's the expert in egg freezing. Well, we're all experts, but Dr. Wais.
I will admit, I wrote the egg freezing section on the Markham Fertility website, and I love it. So please go to so we launched a new website a month ago now?
About a month ago.
MarkhamFertility.com. Lots of information about egg freezing, the process, the cost. We have it all out there. So that would be a great place to start. And then, getting a referral from your family doctor or nurse practitioner or walking clinic, whatever. And you can come see us and we can talk more about it. And that's a situation where we would do an AMH for sure.
We would definitely do an AMH in that case. Not to tell you, oh gosh, you're not going to be able to get pregnant or anything, but just to know.
Yeah.
What is your ovarian reserve? How many eggs can we get during your egg freezing protocol? Are you going to need one egg freezing cycle or multiple egg freezing cycles depending on your goals and the number of eggs that we want to get for you?
Yeah,
absolutely.
That's also my plug for the new website.
Yeah, you're right. The website was great and you did write that section. That's right. That's right. All right. So another one here is medicated versus natural FET cycle. Which one is better? $1 million question. So you're gonna hear different people say different things about this. I think that there's a role for both of them. So
Yeah.
there are women who have irregular cycles, either because of polycystic ovarian syndrome, because a condition called hypogonadotropic hypogonadorea, which means they're just not menstruating, or because they are perimenopausal or menopausal. So in those women, it's a no-brainer that you need to do a medicated cycle. And they have very good success rate with those medicated cycles. The women who don't have any of those issues and have regular natural cycles, we at Markham Fertility Centre have always been a big fans of doing natural cycles. I am a big fan of doing natural cycles. I try to do natural cycles as much as possible. We do see an improvement in pregnancy rate, but I always caveat this, that there's a selection bias, because women who are able to do a natural cycle are different from women who are not able to do a natural cycle. So because again, menopause or other conditions. So you're not really comparing apples to apples. I don't know that there have been a good study where you take women that could do either and randomize them. There have been studies looking at pregnancy rate for natural cycles versus medicated cycles, showing a very good pregnancy rate, higher for natural cycles. But again, you are really excluding women who are not able to have a natural cycle, period. So I personally, whenever I can do a natural cycle, I would propose to do a natural cycle. But I don't want anybody out there to feel that because they cannot do a natural cycle, they're disadvantaged and they have a much lower likelihood of getting pregnant. The other thing about natural cycles, it does require more monitoring. So if you live really far, if you have a difficult work schedule, that might not be ideal. Natural cycles get canceled more often because we have no flexibility with them. So the lining has to be perfect at the right time. The ovulation has to be perfect at the right time. So if anything is wonky, then we would have to cancel natural cycle and either try it again or convert it or change it to a medicated cycle in another cycle. So there are some disadvantages to natural cycle from that point of view. But when if you can do it, if you can do the monitoring, if you have perfect, predictable natural cycles, I think it's a great alternative.
And I'll just say, I totally 100% agree. We'll try and do a natural cycle whenever possible. There's also a lot of more increasing research sort of in obstetrical outcomes, again, in sort of the risks in pregnancy, blood pressure risk in pregnancy, that natural cycles, that there's something about the act of ovulating, so when a woman ovulates, so in a natural cycle, you ovulate, meaning you grow a follicle, the follicle bursts, the egg gets released, and then that follicle closes up again, becomes a cyst called a corpus luteum. But there is increasing evidence to show that in these natural cycles, there's lower rates of preeclampsia, blood pressure issues, like later in pregnancy, in the third trimester, etc. And I think that's really, really interesting as well. So again, if somebody can do a natural cycle, then that is definitely my preference for sure. And the pregnancy rates between natural cycle and medicated cycle, like, they're not miles apart, the pregnancy rates. We're talking about, there's some studies that show the medicated is better, some studies show natural is better. It's the difference in pregnancy rates is really not actually that far apart. But obviously when you're trying to get pregnant, when it's your embryo, every percent is huge, right? So it's all relative.
Absolutely. All right, we're gonna answer one more question and then we have to go. We're gonna be back next week, so we're gonna answer the other questions next week, and we're also gonna answer whatever questions you submit next week as well.
So please send in questions.
So don't worry, we're getting back to you, but we do have to go at some point. We could be here all day if you let us.
It's actually kind of fun. If somebody brought us more tea, like, I'd totally be happy.
And snacks. We need snacks next time.
Yeah, at some point we'll need snacks.
So the last question is, should a septum be removed prior to trying to conceive?
Ooh, that's a good question.
All right. The short answer is no. So this is what we're talking about, that when you haven't really tried, you don't really know what the potential is. So back when I used to do general gynecology and it wasn't only fertility, I would be doing sonohistograms in women in their 60s and their 70s because they're having issues with postmenopausal bleeding, and a sonohistogram is a test, and I saw lots of septums. And I would ask them, hey, what happened? Oh yeah, I had 3 kids, no problem. I didn't even know it was there. So we do know that having a septum, just the act of having a septum, doesn't automatically mean that you're going to have problems with conception or that you're going to have recurring implantation failure or recurrent miscarriages. Removing a septum is a surgical procedure. There are risks associated with that. There's a risk of infection, bleeding, perforation, scar tissue formation, uterine rupture. So it's not something to be considered lightly. So the recommendation would be that if a septum is there and you haven't started trying to conceive yet, you don't need to remove it right off the bat. Mm-hmm. Now, as you get through your journey, and then there was a study that was published recently saying that even in IVF, even in frozen embryo transfer, even if you're having any type of reproductive issues at all, even in those cases, there's absolutely no reason to remove a septum ever. And that study created a lot of controversy in the fertility world. There was a real war happening in the REI groups. And I don't know that I would say that so strongly. I do think that there might still be a role for a septum removal. In some cases, that would be depending on the size of the septum, depending on the reproductive history, depending on embryo transfers and whatnot. So I do think there is still a role for septum removal. I wouldn't go as far as say you don't need to remove it ever, as that study suggested. But certainly, if you haven't even started trying to conceive yet, I would be hard pressed to suggest removing a septum.
Yeah, absolutely. I agree. Yeah, for sure. Mm-hmm. And I mean, I think and it's important to say that you sort of that, you know, if you have a uterine septum, you don't really have any symptoms of it.
That's right.
So again, that's why you can be, 60, 70 and not know that you have a septum until, your 6th or 7th decade of life. And it's really often I'm having difficulty getting pregnant, or I've had recurrent miscarriages, and that's often how we see people end up doing the sonos and finding these septums. I think that's a really different context.
Absolutely.
For sure. And I think it's a matter of having a discussion with your provider. The size of the septum matters too, I think. Oh, yeah. If it's small or big, like inherently, I mean, I think it's going to have a different risk too. Yeah.
Exactly.
Yeah.
All right. Well, that's it. First Life of 2024 done and dusted. Amazing. Nice. Thank you so much for everybody who joined. Thank you for all the many questions that were submitted. We did not get through all of them today, but we will come back and answer them, and keep submitting your questions. And see you next Tuesday at 9 a.m.
Yes, right? Tuesday, 9 a.m. You, me, here. We're going to do it.
With 2 separate coffee mugs.
Yes. Maybe I'll bring a different one.
So this is going to be saved on the Markham Fertility Centre Instagram website. And we're also hoping to put it on YouTube. Okay? All right.
All right.
Bye.
Have a great day, guys. Bye.